We always try to promise you a little open, free-range question and answer stuff. So if Tara and Nadejda wouldn't mind coming back up here again, does anyone have some specific Q&A for Nadejda? Please do chime in if you have something specific.
So for people that are coming off opiates, so not to push them off in the street to get the heroin to replace it, what would be the advantage of an inpatient tapering them off to kind of help work with coping skills?
Of an inpatient treatment process for that? I would love to open this question to all people in this room, but
maybe from a social work perspective, or kind of any sort of behavioral health they might get in a treatment program.
And my first thought would be that there would be, we would be assuming that an assessment process had happened where it was deemed that the level of dependency was such that it would necessitate something like that. Mm-hmm. I was in a group recently where somebody basically said that any legacy patient, anybody that has been on long-term opiates, what we really are dealing with is an addiction issue, and that it should be treated as such. And then basically that an addiction specialist should be screening that person and then making a recommendation for treatment. And so I don't know if I can specifically answer what would happen in a residential treatment program. There would probably be kind of a medical detox process that would be more intensive. There would be behavioral health therapies that would be more intensive.
Well, I guess that would probably be it. Should we consider that when we're talking about taking people off?
So I guess what I would say is if somebody's being tapered and all hell breaks loose, you've uncovered something, right? So I think an addictions consult on all of these folks, and hope that some might be additional training we want to provide to behaviorists, because it might not be that we all have addictions counselors in our clinics. Having that lens on is helpful, but at the same time, I think making that immediate assumption, like that story that you told about that patient. I mean, I've had lots of folks we have successfully tapered down without, compulsive drug seeking emerging out of that. And so I think the options, if somebody, both to do some sort of assessment, but again, what I use diagnostically is if I start to taper and all hell breaks loose, something else is happening here. And that's where we have, I think, then developing some of those referral pathways at the top of the triangle to addictions resource, to methadone clinics, to addiction specialists. If you have providers within your clinic who are buprenorphine licensed, to sort of say, you know what, your opioid system does not function normally with your own normal opioids, and you need some sort of opioid replacement. And that kind of is what it is. You can detox them off of them, but again, I think my gut is that that's not going to go well either, and they're going to need some kind of long-term opiate agonist therapy. And using addiction specialists and pain specialists for that is helpful.
I see that happening often when there isn't this care team model available, where there aren't other resources available. So in an ideal world, they could maybe be on Suboxone, they're working regularly with a behavioral health person, they've got their PCP or pain specialist that's engaged, there's this kind of team approach. And in the absence of that, that's where I see these referrals to inpatient, but maybe in an ideal world, that would be first choice. Yep.
Yes, I looked over here and saw your question over here.
Can you speak to how the effectiveness of gabapentin got into second-line therapy? Like, what evidence is there that it actually works?
Well, I think with gabapentin, so a lot of the evidence that we presented today in Rachel's piece of the talk and mine was based on a few different things. Primarily Canadian guidelines, which is why you saw those cannabinoids in there, because they are able to use those a little bit more in Canada than we are here. And then also if a disease state had a specific guideline. So with gabapentin, it carries the indications for neuropathy. And so it's kind of it's something to think about overall as far as what can happen with some patients is it causes some sedation and it makes them a little bit more sluggish, which if we're trying to get them active, to help manage their pain. Some patients don't do well on gabapentin because of that, is because some of the other modalities that we're trying to recommend to them to help with their pain, the gabapentin's actually kind of inhibiting that. But the primary evidence comes from different guidelines, and then of course the trials that were done in gabapentin to submit to the FDA. Yes. Well, Laura.
Sorry, just a pharmacy question about any evidence about oral capsaicin versus topical capsaicin. I've had some patients express an interest in creating capsules of dried up peppers, thinking that that would be helpful. And I don't know where to direct them on
You know, this is why if it's possible, a patient will figure out how to do it, right? Which is great. And honestly, the answer to my question is I don't know. I would have to look at that and see. I haven't come across any research on oral capsaicin, but that just may mean I haven't come across it. So can I look into it and send it out? Would anyone else in the group, should I send it kind of to the whole group when we send out our slides? Okay, I'll see what I can find for you.
I have a question.
Yes.
Do you ever see there being a national PDMP or even a regional?
That would be
So
great,
like the
wouldn't
people
it?
who are
I
in
don't know.
Washington?
Yeah.
The people who are going over the state line? Is there any talk about that, do you know?
You know, I haven't heard any talk of it. I don't know if anyone, so Christy has heard of it, perhaps.
Not for here, but I'm a licensed pharmacist in Kentucky, and we were able to view patients, I think, in Indiana and like surrounding areas. So it may be something that eventually they allow, just because that's happening.
And you can, as an Oregonian, access the Washington PDMP, and you can do a delegate for that as well. Yep.
And then do you see the nurse as the care manager?
I see whoever has a passion for it as being the care manager. I think nurses would be fantastic. I mean, again, I think it's going to be dependent on sort of what your clinic has available and who's interested. I think a medical assistant on steroids probably wouldn't be sufficient on this one. I think RN, behaviorist, pharmacist, whatever the capacity is, but I think that level of clinical training is important.
I had
Yes,
a question for Rachel. So there's some conversation around opiates where there's a certain point in time, acute moving to chronic therapy, there's a certain point in time where dependence turns into addiction, and it's kind of a fuzzy line of when that is. And I was curious more on the peripheral pain moving to central pain. Is there a time frame for that? Like when we're treating acute pain, are there things that we should look out for, or kind of warning signs? Is there a certain time frame within that, or is there any evidence also?
Well, I would, again, my expertise on this is not infinite. I mean, I think if you're at the 3-month mark, then you're really at a stage where you're like, this is kind of extending beyond sort of healing a peripheral injury to centralizing pain. Oddly enough, the data that Jody Trafton presented is also that's also the period where you move from sensory pain to sort of that reward and emotional pain. That was that 3-month cutoff. So I think 3 months is I would use that as kind of a big red, you're about to come off the cliff kind of sign. But certainly earlier than that could be reliance as well. If you're having trouble, if somebody's saying, yeah, I'm still taking 6 a day, you know, those sort of early warning signs around 4-6 weeks could be concerning as well. I don't know if other folks would add anything to that.
I don't have anything.
I kind of had a question. When just kind of explaining more like expressive sensitivity, like the AMP concept, is that genetically, like, family history, like if your mother was more sensitive to stimuli like lights and things like that, like can you kind of expect in families that exists?
I think it's genetically very heterogeneous, what types of things you're sensitive to, how it shows up. I think it will take many years of sort of gene mapping to figure that out. But I think the statistic was sort of there's a 1 in 3 people have additional family members who have that sensitivity as well. It gets complicated. I work with an occupational therapist who also thinks a lot about sensory processing in people. And again, this is where it gets so complex. Is that a separate phenomenon in terms of how OTs view sensory processing? Is it actually the same phenomenon, looking at it from 2 different disciplines? So I think there's going to be a lot of overlap in trying to tease these concepts apart in subsequent years. But anyway, to answer your question, there is genetic association, but it's quite heterogeneous in the different types of genes and what's expressed by those genes.
We could do questions all day, but I think in the interest of time and everything else, we want to just make sure we tie a bow on here today. Could you do me a favor and give our three presenters a huge round of applause today?